You're listening to the Game on Glio podcast with Shannon Traphagen.
Welcome to Game on Glio, the podcast providing hope, inspiration, education, and real conversations around the difficult journeys of being diagnosed with brain cancer, including glioblastoma. I'm your host, Shannon Traphagen. Follow us on Facebook and Instagram at Game on Glio Podcast, or visit our website, the Game on Glio Podcast, for insights and guest snapshots. If you enjoy our show, please consider writing a review. Also share us with a friend. This podcast is in partnership with Brains for the Cure. Learn more at brainsforthecure.org. Good morning, everybody. I was thinking about what I wanted to say going into this last episode of Season 1. I can't believe we've accomplished an entire season of a podcast centered around brain cancer stories, journeys, and grief and loss. I'm absolutely amazed at what we have put together and what we have done and how far we've come. And I am so excited for the journey ahead and the start of Season 2, which is just so remarkable. As I was thinking about what I wanted to say going into today's episode, which happens to be about pediatric brain cancer, not exactly a topic that is easy to discuss. And I was brought back to a post I did a couple of years ago from the movie Frozen 2. It seemed fitting that as we talk about pediatric brain cancer, we talk about this amazing, wonderful movie that inspires and entertains both children and adults alike. It was a specific clip from a conversation that the character Anna has with the character Lieutenant Destin. And it starts out with him saying, "When you think you've found your way, life will throw you onto a new path." And Anna says, "What do you do when it does?" He responds with, "Don't give up. Take it one step at a time and just do the next right thing," she replies. And he says, "Yeah, you got it." Each of us is on a journey, on a path of self-discovery. Just when we think we have got it figured out and we've got a handle on where our path and where our life is going, life throws us onto a new path, whether we want it to or not. And it's all about what we do, how we respond when that happens. Not giving up and doing the next right thing is so important. It's hard to believe that this is the journey that I am now on. I didn't foresee this path. I had a path set. I thought I had it figured out. Mike and I knew where we were going. We had a family on the way, children. We were becoming parents. I'd gotten published. His career was going well. We thought we had it figured out. And then life threw us both onto a new path. Life threw me onto a new path. And it is not something any of us could have foreseen. And I did not know what to do. I really didn't. After I lost my best friend, my soulmate, I had no idea what direction to go in. I didn't know where to start. I just knew that I didn't want to become lost. I didn't want to become depressed. I didn't want to become angry. I didn't blame anyone. And I worked really hard to maintain relationships and connections with those that were associated to both of us. And I lost a lot of secondary relationships after his death, at no fault of mine. This is just the nature of it. And I've had a hard time accepting that. This journey has been one of extreme pain and emotion and fear and self-love. Like Christine Carlson, who was our guest on episode 11, said, "I have one life vest. I can't fix everybody else. I can only fix me." And for a time, that was true. But I knew along the way that I wanted to find a way to help everybody else that has been affected by brain cancer. I wanted to let those of you who listen to this show know that you're not alone. You will never be alone on this journey. And if my podcast, my stories, help in some small way, then that makes all the difference in the world. And I'm so unbelievably and profoundly grateful for all that we are accomplishing on this journey. Not a path I saw myself on. And as we gear up for season 2, the exciting part of that is we'll be incorporating not just brain cancer stories, but grief and loss stories, stories of resiliency, and great stories about new tech that's coming to light to help the brain cancer community. I'm also going to be doing a lot more fundraising for organizations as we go along to support foundations and organizations that are battling brain cancer, that are finding cures and clinical trials and trying to find new ways to treat this. I will be working really hard to back them. Could I have foreseen that this is where I would be right now? No. And as I enter this new phase of my life, I have found moments of joy and happiness that I did not expect. And I still spend a great deal of time mourning the loss of my husband, mourning the life that should have been. I struggle to see friends and those I know with little kids, with their families, being parents, creating memories. It's hard to sit in an empty house, having lost so much. But I get up each and every day knowing that I am impacting and making a difference in somebody else's life, that I am helping somebody else by sharing my stories. And I'll continue to do that because it isn't just about the loss of a husband. It's about the loss of a life. It's about the loss of dreams that have been forsaken. It's about infertility. It is about the loss of children. And it's about renewal and self-discovery. For many of you, you know exactly what I'm talking about. When something like this is dropped on your doorstep, whether you're the patient or the caregiver, you don't realize how you're going to respond until it's right in front of you. You don't realize how you're going to handle the information, how you're going to step up. I was very surprised at the fight that I had inside of me, not only to save his life and to protect him, which I so desperately wanted to do. I just wanted to shield him from any hurt or fear. I loved him and still love him fiercely. But after he died, I was surprised at my capacity to pick myself up by the bootstraps and find a way forward, not just living, but finding a way to be a voice, to help others, to make a difference. I didn't realize how much I cared about that. And this is the path that I now find myself on, something I am profoundly grateful for. Even in the moments of mourning, even in the moments of sadness or anxiety, I am so grateful that this is the journey that I'm on and I get to share this with all of you. And that's what life is all about. Isn't that what the movie Frozen 2 tells us? It's about self-discovery. So no matter what is laid before us, no matter how big or how small, if we truly look inside of ourselves, I think each and every one of you will find that you have a fight and a resiliency to keep going, to have hope and inspiration, and to just keep moving forward. We have so many amazing guests coming up for season 2, and I cannot wait to dive in, to share some of these new, great, wonderful stories with you. But in the meantime, we still have one episode left of season 1, and I am so excited to have these 2 doctors on Dr. Hoffman, and Dr. Green, who are going to be talking about their journeys with pediatric brain cancer, what they're seeing as the struggles and the barriers, how it differs from adult brain cancer, and give us some information into the work that they do day to day. And we will be talking to them next after a quick word from our sponsor.
When my mom was diagnosed with a brain tumor, I didn't know where to turn. How do I prepare myself as a caregiver?
As a 22-year survivor, I've talked to hundreds of patients, mostly just listening and answering questions. I've visited dozens of websites, some good, but none I thought truly met the needs of survivors and caregivers. I found what I was looking for in Brains for the Cure.
This is a resource I've been looking for. Not only did I learn a lot, but it also reassured both of us that we are not alone.
With resources and news from Brains for the Cure, patients and caregivers can advocate for themselves and become decision makers in their own journeys, learn about treatment options and clinical trials, and connect with other patients, survivors, caregivers, and medical professionals through our ambassadors, online support groups, and personal stories. Find out more at www.brainsforthecure.org.
Hi, we are back. Thank you so much for joining us on the very last episode of Season 1 for the Game on Glio podcast. I am joined today by Dr. Lindsey Hoffman and Dr. Adam Green. Dr. Hoffman is the Director for Neuro-Oncology and Cancer Predisposition at Phoenix Children's Hospital. She's also the chair of the International Diffuse Intrinsic Pontine Glioma Registry. Dr. Green is the Associate Professor of Pediatrics at the University of Colorado School of Medicine and the attending neuro-oncologist at Children's Hospital Colorado. Dr. Green focuses on novel targets and therapeutic strategies in the treatment of pediatric high-grade gliomas. Thank you both for joining me today.
Thank you, Shannon.
Yeah, thank you for having us.
We're kind of talking about a pretty heavy-laden topic here when it comes to pediatric brain cancer. So I'd like to ask both of you, and Dr. Hoffman, we'll start with you. Why did each of you guys decide to go into pediatric brain cancer as your field of interest?
For me, it was an early experience in my medical education that gave me personal insight into the sort of personal and family sides of what we do every day, as well as the scientific side of pediatric neuro-oncology. Mm-hmm. And so specifically, I was accepted into a summer internship program at St. Jude Children's Research Hospital in Memphis. And this was between my first and second year of medical school. And I was assigned to work with a pediatric neuro-oncologist. And so I had the opportunity to interact with patients and their families, and then also to understand and be excited by the scientific aspect of pediatric neuro-oncology. And I found both to be very compelling, and the rest was history for me.
And Dr. Green, what about you?
Yeah, it's kind of a similar story. So I was interested in neuroscience, and I'd done some neuroscience research in college. I kind of always knew I wanted to be a pediatrician, but I thought maybe I wanted to be a pediatric neurologist. And then when I got to medical school after first year, I got to work with a pediatric neuro-oncologist, and it just seemed like a field where, obviously, as you said, these are very heavy issues and very sick patients, but I liked, kind of having the chance to potentially, save a patient, a long, as normal life as possible. And to approach disease from the perspective we can potentially cure them instead of just manage them. And it was obviously also this really amazing field of research. And so, from there, I got involved with some research and got to meet a lot of patients and stayed with the field from there.
Wow. When you talk about the field of brain cancer and this disease that has affected so many people's lives, you often don't think about the pediatric side of this, as I'm sure with any cancer diagnosis for most people, thinking about a child being affected by such a traumatic and heavy disease. It's hard enough being an adult walking that path, let alone being diagnosed in pediatrics. You guys both focus on some very unique aspects of this, and I'd like to dive into that a little bit. Dr. Hoffman, for you, you're the chair of the DIPG, which I had just mentioned. Can you explain to us what that is a little bit? I've never heard of intrinsic pontine, so I don't know if that's a specific type of glioma only found in children, or what does the name actually represent?
Yes. So DIPG, or diffuse intrinsic pontine glioma, really is a much more pediatric tumor than an adult tumor. And it's a relatively rare tumor overall. So the incidence is not perfectly known in the US, but it's about 1 to 2 patients per 100,000.
Oh, wow.
And it preferentially impacts children between ages 5 to 7 and is rarely diagnosed in adults. So it really is, again, much more of a pediatric specific tumor. And given its rarity, there has been focus on understanding the biology of the tumor and how we can formulate better treatments for this tumor.
I just want to follow up with, you said between the ages of 5 to 7 is the most common, the typical. Is there a reasoning, or is there research or something that explains why between the ages of 5 and 7 there's that vulnerability for the diagnosis?
So that's a great question. And that is still being understood. And Dr. Green can weigh in on this too, just from a tumor biology perspective. But it is likely a neurodevelopmental hiccup or mistake that happens. We recognize there's a specific mutation associated with this tumor that is characteristic of the tumor in a histone gene. And it's believed to be, as the brain is undergoing early development through childhood and then later adolescence, there's sort of a natural programming of ways that genes get turned on and off, and in the way the brain is formed. And so this tumor is specific to the pons, which references the location of the tumor.
I see.
And again, we believe it's sort of a developmental pattern in terms of why the tumor arises at that specific age and in this location.
Okay. Dr. Green, statistically, how many children in the U.S. are diagnosed with DIP gliomas and subsequently GBM, glioblastoma? Because while we are talking about gliomas in general, there are kids that are diagnosed with glioblastoma. So can you talk a little bit to the statistics of how many children you guys are seeing in the area of these brain cancers? And are these the only 2 types of gliomas found in pediatric brain cancer?
So we would say that there are about 250 to 300 kids in the United States diagnosed with DIPGs each year.
Mm-hmm.
And then when we extend that out to the whole category of high-grade gliomas, which also includes glioblastoma, that would be more like maybe 500 children per year in the US.
Okay.
The nomenclature and the types of high-grade gliomas is somewhat it's always changing. People may have heard the term diffuse midline glioma too, which includes, DIPGs are the most common type of diffuse midline gliomas, but then there are also other locations where those can occur. But, when we talk about high-grade gliomas, those are kind of the 2 main subtypes. And when we talk about glioblastomas, those tend to be tumors that are more like the adult glioblastoma. So instead of occurring in a midline, kind of brainstem or midbrain location like DIPG, those tend to occur in the larger parts of the brain, the cerebral hemispheres, although not always.
Mm-hmm.
There are other types of gliomas that occur in kids that we call low-grade gliomas. We don't tend to consider those brain cancers because they don't really follow cancer-like behavior. We don't call them benign because that kind of understates the kind of damage they can do. They can cause a lot of problems just by growing in the brain, but they definitely have a much, much better prognosis than DIPGs, glioblastomas, and other high-grade gliomas, which are certainly cancerous. Okay. And the low-grade gliomas are more common than the high-grade gliomas, and again, are sort of another type of tumor that we deal with, but something that is much more treatable and curable than high-grade gliomas.
Now, let me follow that up by asking, so whether it's a high-grade glioma or a low-grade glioma, primarily with, let's say, a low-grade, because they seem to be a bit more prevalent based on my understanding of what you're talking about. Do you think there is a reasoning or a pattern or some type of driver that is causing these to occur in children this young?
It's a great question. As far as we understand, the development of these tumors is really random in most cases. There are patients who have predispositions, so have genetic risk factors that are kind of present in all of their cells from birth that put them at risk for developing these kinds of tumors.
Okay.
So an example would be neurofibromatosis type 1, which is a cancer predisposition that's one of the most common, and that puts patients mostly at risk for low-grade gliomas. But again, we don't really know of risk factors. There is a risk factor of radiation that patients may have received for prior treatment of another type of cancer that put them at risk for these. But again, that's very unusual. So really, in most cases, unlike in adults, where adults may have some kind of lifestyle or other risk factors like that for cancer, those don't tend to be present in kids. And so most of these really just occur as random events. It's one cell that undergoes a very powerful genetic change randomly and then is able to form a tumor.
I see. Dr. Hoffman, let me ask you this. This kind of plays off of, what Dr. Green was just saying. What does recovery and remission look like in the area of pediatric brain cancer patients versus that of adults?
So that's a really great question. And it's actually important because there are definite distinctions in what children versus adults can handle, just in terms of toxicity of treatment. So broadly speaking, children are able to handle much more toxic therapy than adults, and they often sort of sail through a very intensive chemotherapy, which we use for a lot of tumors. And this type of chemotherapy would be intolerable to an adult, both in terms of organ function, as well as just the psychological impact of really intensive treatment. So children are, as we all know, amazingly resilient human beings, and the impacts of their treatment are really hard, but I would say harder on their parents often than the children themselves, who kind of get through very well for the most part. So I would say, in terms of something unique to pediatrics, although this would be true for adults too, but I would say the hardest part of getting through treatment and getting into remission, a lot of that pertains to just their readjustment to re-entry into normal life. And I use normal in sort of quotation marks because it is a new normal during therapy, and then their adjustment back into life can be a little bit challenging, just readjusting to school and their peer groups, and then still often feeling physically drained from different aspects of their treatment, which can take months and even in a lot of cases more than a year to kind of get back to themselves.
I find that really interesting. Part of me, as you're talking, it makes me think that, gosh, I wish adults could handle the same type of treatments that the children tend to get. But children are so much more resilient as far as, how young they are. And maybe that plays into how children handle chemo and radiation treatments and different therapeutics compared to adults. I am curious, are there treatment options available in pediatric cases that are not available or usable in adult cases?
Yeah, that's a great question. So there are. So for instance, we will often use, and as Dr. Hoffman was referencing, additional chemotherapy medicines for pediatric high-grade gliomas that are not as commonly used in adult treatment. It's also the case that we know that the biology of pediatric high-grade gliomas is different from that in adults. And so the genetic changes in the cells that drive the tumors to grow can be different as well. We know that. And we don't really have medicines kind of targeting all of those genetic changes, but we're starting to have some, to have medicines directed at these genetic changes that are specific to the pediatric tumors, allows us to have specific treatments for pediatric high-grade gliomas that wouldn't be usable in adults.
I completely agree. I think it depends a lot on the tumor type and the genetic driver of that tumor in terms of what, medications are relevant. I was just going to add, though, sort of more broadly related to that topic. So in terms of accessibility to new treatments, It's actually sort of the opposite direction of flow in terms of there are more treatments available for adult cancer than there are for pediatric cancer. So I just wanted to throw that in, that often we in pediatrics are using medicines that are already approved and in some cases have been used for a long time in adult oncology.
Mm-hmm.
And so it's when a medication has proven itself useful in adults that it sort of trickles down in a lot of cases to pediatrics to have access to and to be able to move that forward in relevant cancers in kids. So I completely agree with Dr. Green that it depends on the tumor type and the relevance of that medication. But there's more ability to get access in peds now versus 10 years ago.
Mm-hmm.
And that's a lot related to just incentives given to pharmaceutical companies and things to test these medications in children. And so we're in a much better space now than we used to be. But even still, pediatrics, we sometimes lack access to some medicines that could be relevant.
Well, that's interesting. And I never would have expected that the advancements in the way adults are treated is further along in some of the treatment options that they have afforded to them. Before I go into the next question, I am curious. I know that there is devices out there that are used in adults. And for example, the Optune device, a cap that adults use when being treated with glioblastoma has been proven to kind of lengthen, give some longevity to a person's life that's been diagnosed with glioblastoma. Do you know if that's something that is an option for children that are going through brain cancers, high-end gliomas like glioblastoma, or is that not something that's viable for them?
It actually is viable, and it's currently in phase 2 trials in children, not just with high-grade glioma, but in other tumors that have come back, so tumors that are progressive or recurrent. So that trial is being done through the Pediatric Brain Tumor Consortium,
Mm-hmm.
and I think is a really important trial because I think part of what's being understood is just the practical nature of wearing a device like the one that you mentioned,
Mm-hmm.
especially in a child who may be a little bit less tolerant of that, having something adhered to their scalp.
Mm-hmm.
The relevance it's shown in the adult GBM space certainly makes it worthy of evaluating in the pediatric, in different pediatric tumors.
Mm-hmm.
So part of that trial is focused on just the feasibility of getting that treatment or adhering to that treatment for children, but also then the efficacy.
Mm-hmm.
And I think it's really exciting because, if it's tolerated, we could then define what can we add to that treatment to augment it, to make it better.
Absolutely.
Medications by mouth that could be given at the same time, things like that. So I think it's really exciting, and I'm glad it's being studied in children.
Well, I'm glad that I brought it up then, because I think that this is what this podcast is all about. So having relevance to these kind of treatment options and technologies that might be afforded to, both pediatric and adults, for families to be aware that these things might be relevant and might be available for them is vital. I want to follow this up with, and Dr. Hoffman, this is to you, the difference between pediatric CNS, I think it's pronounced germinoma, and an adult CNS GBM. And the reason I ask about this, so CNS is cerebral spinal, the nervous system in the spine. And why is survival strong for these germinomas, but not for these leptomeningeal cases, which is what tends to occur in adult glioblastoma cases? And there's a reason I poached this question, but I found this very interesting.
So, when we think of leptomeningeal disease, it's a way to describe how a tumor has spread. And there are certain tumors, such as germinoma, as you referenced, that is actually pretty commonly spreads and may spread along the meninges. So that's the lining that covers the brain and the spine. When a disease or a tumor has spread to the meninges, we call that leptomeningeal spread. Tumors can also spread or metastasize in other ways, where they kind of jump to a different area of the brain or the spine. And a lot of it comes down to, in terms of, the prognosis when a tumor has spread leptomeningeally or metastasized in any other way, a lot of it has to do with what kind of tumor it is in the first place. And a tumor like germinoma, for instance, is is very treatable and curable even when it has spread. And so it may be that we modify the treatment plan a little bit, and that pertains more to sort of where radiation is given if it has spread versus not. But germinoma is very, very responsive to both chemotherapy and to radiation, very differently than GBM or other tumors that may spread to the leptomeninges. So really it comes down to tumor biology and how responsive the tumor would be to the treatments that we have available.
Okay, that makes sense. I've never heard of germinoma before. So as I was researching that and looking into these nuances of some of these different gliomas and different brain cancers, this stood out for me. And, up until, to be quite honest, until my husband passed away, I had never heard of leptomeningeal spread. And I didn't know that that was a thing when it came to GBM, because when you hear glioblastoma, they keep saying it tends to stay housed within the confines of the brain. It doesn't make it much better, but you don't expect it to metastasize into the cerebral spinal fluid. So that had caught us off guard because it seems to happen in very small subset of cases, which unfortunately included my husband. So when I was looking at the fact that this type of spread along the meninges can take place even in pediatric cancers, brain cancers, I was curious to see the difference between a leptomeningeal spread of GBM versus that type of spread for something like germinoma. So I appreciate the explanation of that.
I think that sort of speaks to the differences between pediatric and adult cancers in a lot of ways. So in the pediatric realm, we do have actually a fair number of tumor types that are prone to spread or disseminate. And that's pretty different than adult brain cancer, which, as you mentioned, does tend to stay put most of the time. Now, that's not always true, but in the pediatric realm, diseases like medulloblastoma or germ cell tumor, as you mentioned, germinoma is one type. We, in a lot of cases, expect that they might have spread at the time that we've found them. And so we treat accordingly with radiation to broader areas of the brain and spine. And then, of course, chemotherapy, which we use pretty proactively in the pediatric realm. That, of course, addresses disease that has spread as well as the localized tumor. So it kind of speaks to the differences between the types of brain tumors in kids and adults as well.
Okay. Dr. Green, I'd like to move to you. I'm curious to know what type of new therapies or treatment options are becoming available in pediatric brain cancer that might not be on families' radars or on communities' radars, that it might be walking this journey?
So I'd say that they fall in a few different groups. One I kind of mentioned before was, kind of these newer chemotherapy agents that instead of sort of attacking all of the tumor, kind of fast dividing cells in the body like older chemotherapies do, attack specific weaknesses in a specific patient's tumor. So that's one. There's also been a lot of effort toward harnessing the body's immune system against their cancer. And some of those treatments have been very successful in adult tumors and have become FDA approved. So and that kind of references specific medicines called checkpoint inhibitors that sort of reveal hidden tumors to the body's immune system. Those, as of yet, haven't been as successful in pediatric tumors, although there's still some attention. The treatments that have been exciting and kind of revolutionary in some other types of pediatric cancers, especially leukemias, have been treatments called CAR T cells, which are basically white blood cells that usually attack infections that are removed from a patient's own body, kind of taught to attack the patient's tumor and then put back into the body so they can attack the tumor. And as I said, those have been really successful in pediatric leukemias and are now being studied in pediatric brain tumors.
Wow.
And we know that it's harder for those cells to be successful when it's a solid tumor as opposed to a blood tumor like leukemia. But I think there's a lot of excitement about those as well. And some other kind of types of therapies harnessing the body's immune system. Two categories of newer options that are becoming available and certainly under investigation in pediatric brain cancers.
So to follow up with that and to kind of jump on this, you had recently done a study regarding potential new treatments for focal brainstem gliomas and DIPG. Can you tell us what you found with that, and what does that mean for treatment options for children?
Yeah, so my research is, as you said, focused on finding new treatments against specific types of pediatric hypergliomas and kind of studying those in the laboratory and then trying to bring the most successful ones to pediatrics. And so, we've studied some new chemotherapy medicines, as I mentioned, that are kind of more focused on the specific cancer cells as opposed to kind of all the fast dividing cells in the body.
Mm-hmm.
And we have an upcoming clinical trial that will be open nationally studying one of those targeted medicines. We have also done some work looking at specific weaknesses that are in hypergliomas in very, very young children, those who are either born with hypergliomas or are diagnosed with them in their first year of life. And we know that those tend to be very different than those in older children or adults. They actually tend to be a lot more curable. And we've found some specific reasons that might be in terms of the genetic weaknesses in those tumors that are different than ones in older children and adults.
Mm-hmm.
And those are ones that we often do have, kind of targeted medicines against that, as Dr. Hoffman mentioned, are used in adult cancers, other adult cancers, and now we can apply them to these, infant and congenital pediatric hypergliomas.
So you mentioned within that there's a clinical trial coming up. Is that something where you guys are looking for pediatric patients to possibly get involved with? Is there information you want to share with everybody regarding the clinical trial so people know where to go or how to look for it?
Yeah, so this particular trial will be open to kids who are newly diagnosed with DIPGs and other pediatric hypergliomas, and we'll study targeted chemotherapy medicine called selinexor, which is approved in a couple of adult cancers, and we've been studying it in pediatric hypergliomas, and it'll be combined with the radiation that those patients would receive as part of their initial therapy anyway, and we hope that the two treatments together will be kind of more effective than the sum of the individual effects.
Okay.
The website clinicaltrials.gov is a very useful resource for searching for new trials. You can search by kind of specific disease and specific, kind of keywords, specific institutions where trials may be open. So that's another great resource.
Okay, perfect. Dr. Hoffman, I'll throw this over to you. I'm curious, in dealing with pediatric brain cancer patients, it's the same as with adult patients. There's this constant conversation around part of the reason it's so difficult to treat adult patients is this whole idea of being able to break the blood-brain barrier. And so I'm curious to know, is it easier to break through the blood-brain barrier in treating pediatric cases versus adult cases? And if so, why?
So that's a really important question, and one that I don't have a perfect answer for. I don't think any of us do in terms of understanding the blood-brain barrier. So in terms of distinction between pediatric and adult, to my knowledge, there's not a great distinction between the blood-brain barrier in a child versus that in an adult.
Okay.
But it makes it equally formidable, between the two, in that it is a challenge to overcome the ability to push drugs across that lining into the brain where it needs to act. And so there are certain things like radiation therapy is well understood to open up the blood-brain barrier. And so sometimes there are efforts to try to utilize using medicines that we don't believe would cross the blood-brain barrier well in the context of radiation to get more across, for instance.
Mm-hmm.
I guess one unique thing in pediatrics related to the blood-brain barrier is that even for standard chemotherapy medicines, we talked earlier about tolerance of giving chemotherapy in kids, their tolerance is better. And so we use a fair amount of high-dose chemotherapy to the philosophy or theory being that we can push more chemo across the blood-brain barrier when we give it at very high doses. And again, children are much more apt to tolerate that than adults, and it's relevant for the diseases we treat. So there are some ways that we can maximize transport across the blood-brain barrier, but we certainly recognize, especially in the realm of newer targeted inhibitors, some of them have mechanisms or, it could be the size of the drug molecularly that we understand that it probably won't get across the blood-brain barrier well. But I would say in general, in pediatrics, there's more effort in understanding the concentration of the medicine that gets to the tumor or gets into the spinal fluid that cushions the brain and spinal cord. And so more and more we are building components or aspects of clinical trials that are getting pushed forward. We're building in this phase 0 portion where a dose or two of the medication is given before a patient goes for a planned surgery. Things like that can help us really understand how much of that medication is getting where it needs to go. And based on that information, how likely do we think it will be to succeed? And sometimes that will change the direction of how we use a medicine based on that information.
Great answer. And I would also just add that, there are a couple of, I think, exciting strategies that are under investigation to try to kind of deal with the blood-brain barrier in pediatric tumors.
Mm-hmm.
One is called focus ultrasound. So kind of applying ultrasound like would be, used in pregnancy, things like that, but in a very focused way to the area of the tumor. And allowing that may kind of open the blood-brain barrier to medicines that usually wouldn't be able to bypass it. The other is called convection-enhanced delivery, which is basically inserting catheters directly into the tumor.
Oh.
And kind of using that to deliver chemotherapy kind of directly into the tumor
Mm-hmm.
in advanced ways. And I'd say both of those strategies could be applied to both kids and adults, but are probably a little bit more likely to be successful in kids in types of tumors like DIPG and diffuse midline glioma, because the tumors tend to be in a little bit more restricted anatomic area, whereas kind of glioblastomas that, as we've said, occur in both children and adults, tend to be kind of so diffuse and widespread in a part of the brain that it can be kind of hard to kind of deliver a local treatment to the whole thing. So
Okay.
I think, those are both under investigation. I'd say still fairly early in investigation, but hold a lot of promise for, bypassing this issue of the blood-brain barrier in kids.
Interesting. In children that go into remission from brain cancer and then grow into adulthood, is there a higher probability that they'll develop brain cancer or another type of cancer in adulthood because of the diagnosis of brain cancer in childhood?
So that's a really good question, Shannon. And it's not a one-size-fits-all scenario, but there's several factors that play into risk after a child goes into remission from a primary cancer. So one of those pertains to their underlying genetics, which we've touched on a little bit. And we have learned more over time, really in recent years, that a person's inherited genetics does play a role in some cases. There would be some patients for whom their risk would be higher just because of their inherited genetics, what they inherited from their mom and their dad. And then separate from that, but can be related, a lot of that is based on the type of therapy that they received.
Mm-hmm.
It's well known that certain types of chemotherapy can bring higher likelihood that they'll develop another type of cancer. For instance, a secondary leukemia, unfortunately associated with some types of chemotherapy. And thankfully the risk is low,
Mm-hmm.
but not zero. And the other big category we think of is radiation,
Right.
which we know can induce secondary tumors, including, unfortunately, secondary high-grade gliomas, which is very, very unfortunate, but also secondary meningiomas are the most common, often decades later.
Oh.
And so what's really important in peds, and that I think we do this pretty well, is to help guide patients and parents and families to understand their risks.
Mm-hmm.
So, in fact, most programs have what we refer to often as kind of a long-term follow-up or a survivorship clinic. And we follow kids, even if they're diagnosed as a toddler, we'll follow them into their definitely late teens, if not early to mid-20s.
Oh, wow.
Yeah, so there's really we're not going to boot them out the door to their primary doctor or their, or into the adult realm very quickly. We hold on to our patients and really follow them through their childhood and adolescence and try to guide along the way so they understand what their risks are based on what they received and do appropriate surveillance where necessary.
Dr. Green, I'll ask you to follow up on what Dr. Hoffman was just saying. And then along with that, do you see a trend with pediatric brain cancer where they go into remission and then develop brain cancer as an adult based on, is there a high recurrence of that brain cancer specifically in the adults?
Yeah, so we would separate the development of a secondary cancer, which we would take to mean a cancer that develops directly because of the treatment that was received. And as Dr. Hoffman said, those do happen, but they're rare. So we're always trying to come up with treatments that are less toxic, and obviously that's a very important toxicity we think about, and trying to minimize that risk. But with the treatments that are currently available, we always say that we need to treat the cancer that patients currently have, and then kind of deal with what could happen later. That would be a separate issue from a recurrence of the cancer, which we would take to mean the original cancer that we've treated that then comes back despite treatment. That happens much more commonly. And, with something like pediatric high-grade glioma is really the rule that, it's very rare to be able to cure a patient of high-grade glioma
Completely.
By which we mean you kind of make the tumor go away and never come back.
Right.
Those almost always recur. And when they recur, they're generally harder to treat because they're often resistant to the treatments that we've already used. And it's sort of the most aggressive cells that are the ones that have survived the previous treatment.
Okay. Dr. Hoffman, how do you feel the field of pediatric brain cancer is changing or evolving when it comes to understanding, diagnosing, and treating pediatric brain cancer?
So I think it's evolving in a really exciting and hopeful direction. And I think from, the time I referenced, I was in medical school very early in my medical training and was struck by how amazing the field of pediatric neuro-oncology is. I feel like I haven't lost any of that excitement about how far we've come and how far we have yet to go, but there's good momentum. So I think one aspect of that is the way tumors are classified and the better understanding we have of the genetic basis of pediatric brain cancer is constantly changing, and we're understanding more and more and have deeper understanding of the mechanisms that drive pediatric brain cancer. And so this has in some ways made classification of pediatric brain tumors more challenging over time because it's gotten much more complex.
Oh, interesting.
Yeah, but it also represents that deep understanding of the biology. And I think what's hard for me, as I'm more on the clinical side than the laboratory science side of things, what I find challenging is just the disconnect or delay between how much we know about tumor biology and what we can do about it therapeutically. And so the science is far ahead of therapies and clinical trials. And we are making progress in terms of transitioning. We often reference bench to bedside, taking something from the laboratory and getting it into patients where it can do some good. That transition is sometimes frustratingly slow. But in pediatric neuro-oncology specifically, there are numerous different clinical trials consortia, people really working together collaboratively to push forward trials as quickly as possible. So this gives me just a lot of hope in general.
That's amazing to hear. And that hopefulness is something that resonates with a lot of our listeners because that's something they need. Frankly, we all need that when we're walking this path of dealing with something like brain cancer. Dr. Green, do you feel there are more advancements taking place in the area of pediatric brain cancer versus that of adults? Is there more progress being made in options that are maybe in the pipeline, or do you feel it's kind of leveled out, that they're fairly balanced?
Yeah, Shannon, I think it's mixed. And the issue in pediatrics gets to the issue that Dr. Hoffman just brought up. It's that there's been amazing work to understand the biology of pediatric brain cancers in the past 15 years. We really have a lot of understanding now. And I'd say, on the pediatric side, once we have, kind of new treatments to try, we're really good at all working together, among institutions, among countries, to test those treatments through cooperative clinical trials in patients. but making that link be, so developing the treatments that will, kind of correspond to that biological understanding of the tumors that we have is the biggest challenge that we have. And that's because these tumors are so rare that, that is a step, kind of developing the drugs and treatments that often is a step that is led by the pharmaceutical industry. And these tumors are so rare that there just isn't as much interest from the pharmaceutical industry in kind of taking that step. This is being addressed. I think that, there are new pharmaceutical companies and biotech companies that are specifically, trying to address pediatric brain cancers, but it's definitely a challenge. We're pretty resourceful as a field. So I think we are making progress, but it takes a lot of creativity and cooperation. But I share Dr. Hoffman's optimism that we're close and we can do it.
And I'm right there with both of you. Just within the numerous guests that I've had on from a clinical and laboratory perspective for the adult side of it, there is this underpinning hope that this can get done. And the challenge seems to be fairly similar for both pediatric and adult. There's this resonating theme that I've heard over and over again, that it's in taking what can get done in the lab, in understanding the nuances and the behaviors of brain cancer. And once something is found that could be potentially viable to work, then getting it into the clinical setting and getting it into the hands of patients and families. And that has been a common frustration and a common theme among all physicians and doctors, neuro-oncologists, clinical researchers. Brain cancer is kind of a ticking clock. And so making sure that anything new that comes down the pipeline can get into the hands of patients is just so vital and so important. So I love hearing that there is just so much fight and so much hope in both the pediatric and the adult brain cancer. It's just, this work is just so necessary and so important. And it's people like you guys that kind of carry the families through. I can't imagine being a parent and being handed this diagnosis that your child is going through brain cancer and they're 6 years old, 7 years old. My question to both of you, and we'll kind of end with this, because of this type of work, because of the area that you guys are in and the work that you do, it's a heavy, heavy field and it can really weigh on people. What do each of you do to decompress and kind of leave the burdens, if you will, at the door of work when you get home at the end of the day?
Yeah. I'd say, a couple of things. I do really get a lot of, I guess, kind of reassurance and happiness from being able to just talk directly with colleagues and families about these things, and also, kind of have a combination of work in the lab where we're trying to come up with new things and then taking that to the clinic and, seeing those applied there, and then taking the biggest problems we see in the clinic and bringing them back to the lab. I think, kind of having that combination is good, but there definitely need some outside of work decompression as well. And I'd say that for me is getting outdoors, music and spending time with family.
Interesting. Any particular type of music that you really veer towards?
Yeah, so I sing and play piano, so I do some of that on my own. And then in terms of listening to music, I sort of got stuck in my teenage years in terms of like 90s alternative rock. So that's still my favorite. Yeah,
I'm right there with you. And Dr. Hoffman, what about you?
I echo a lot of what Dr. Green said in terms of just sort of speaking to the collegiality in our field. We spend a lot of time together, even at different institutions, different parts of the country. We all know each other really well as friends, and we see each other at conferences. And I think the fact that it is a small world makes it more fulfilling and enjoyable, and also allows us to sort of bounce ideas off of each other and makes that, the burden of some days a little bit lighter, in that you can call your colleagues and and really work together. And then I think obviously spending as much time with family and friends outside of work as possible. I think that interfacing with children and families who've been through or are going through the worst really helps me see life through a lens of gratitude, and really helps me understand and keep in mind what's important. So I think that certainly there are days that are really hard, but in general, it's such an honor to walk on this journey with patients and families. And I feel like it gives me more than it takes away in essentially every way. It's a unique kind of spiritual journey in a lot of ways, but I think there are many ways that this being in this field is a blessing, and one that really helps us get through the hard days.
Well, I am very grateful to both of you for being in the field and for choosing to do this type of work. Without individuals like you, we wouldn't be as far along as we are on the journey, even if it seems like we still have a long ways to go. So I'm personally grateful to have all of you working on these very tough diagnoses and these tough cases. Any last thoughts or anywhere you would like to send listeners if they'd like to learn more about the work that you do or do a little bit of research on treatment options? Is there like a website or somewhere where you would like them to be directed to?
So I'll chime in just on the DIPG front, which we touched on, but for the DIPG registry, that is really meant as a resource not only for the scientific community, but also for patients and families. And it offers a lot of insight just in terms of the right questions to ask and how to move along the journey of that diagnosis. So the website is dipgregistry.org. Again, for people who are going through that journey or know people who are, that's a great resource and website to go to.
Okay. And you said that registry, the website is dipgregistry.org.
Yes.
Okay. And Dr. Green, what about on your side?
I think the DIPG registry, and again, that Lindsey leads, is a really wonderful resource both for families and researchers. Mm-hmm. It's such a challenge for families to find reliable information. And again, there's no one best resource or best way to go about this. Families hopefully should rely on their pediatric oncologist or neuro-oncologist for this information.
I will have some of these resources and websites up on the GameOnGlioPodcast.com for all of you who are listening. And I'd like to thank our guests today, Dr. Lindsey Hoffman and Dr. Adam Green, for joining us. Their bios will be up on the website as long as the links for any of the conversations that we were referencing here today. Thank you guys so much for joining us. This conversation is vital. It's important. It's one that needs to continue, and I am so grateful to know you and to have had you on the show today.
Shannon, thank you so much. This has been a pleasure to be a part of.
Yeah, thank you for having us and for perpetuating this really important conversation.
Well, it is a conversation we will continue to have. I know going into season 2, for all of you who are listening, we will actually have some guests on the show that are families of pediatric brain cancer patients currently. And for all of you listening, thank you so much for joining us today. We will be right back after a quick break.
Brains for the Cure is an innovative online resource to help brain tumor patients, survivors, and caregivers become advocates, educate themselves, and connect with others throughout each phase of their journey. We are proud to partner with the Game on Glio podcast. Visit brainsforthecure.org to learn more.
It's hard to believe that we've just completed an entire first season of the Game on Glio podcast. When I started out on this journey, I couldn't possibly have imagined that this is what I would be doing, or that these are the stories that I would be telling. I have heard so many amazing stories and journeys from so many of you, and not just guests on the show, but people who have reached out to us via email, Facebook, DM. So many of you have told us of how inspiring and life-changing listening to this podcast has been. I have met some of you in person at various events. Some of you have been referred to the podcast by doctors who are aware of it. When I look back at all that we've done this first season, I am so proud and so honored to be walking this journey with you. And I think Mike would be proud too. I started this to honor him, to honor his legacy, to honor the path that we had to walk, and to share bits and pieces of our journey, some of which I still have yet to share. And even though he is gone, I think he would be so proud of the fact that this is what I chose to do to find purpose and meaning in his death. I will admit, it is not always easy. And sometimes when I get done recording an episode, I have to take a few minutes to decompress. Sometimes I even cry. I get asked quite a bit, how can you immerse yourself in the very thing that took your husband's life? How can you stay embedded in this world of brain cancer? Doesn't that keep you from moving on, from moving forward? No, it doesn't keep me from moving forward. I think if anything, it's actually helped me move forward, even just a little bit. It is helping me heal by finding a way to help all of you, to help give vital information, to give you guys a platform, to share your harrowing journeys and stories, to give doctors a platform to make appeals, to talk about the work that they're doing. It's actually helping me. I needed to find purpose in his death. I needed to find purpose in all of the loss that he and I had suffered before he even died. And doing this helps that. It helps me find purpose and meaning. If there is any way that I can inspire any of you to stay strong, to have fight, to keep going, then staying immersed in this, doing this type of work, there's no better reward than that. So thank you to all of you who are devoted and dedicated to the Game on Glio podcast. We wouldn't be here without all of you. I also want to give a very big thank you to our Season 1 sponsor, Brains for the Cure. They were an amazing sponsor for us this season, and I am so grateful to have had them on board for Season 1. And I am excited to say that we do have a second season coming up. And I am so unbelievably excited for that second season. And we have some great new sponsors who will be working with us, and I will be announcing those before we kick off in May of 2022, which we will begin with our very first episode honoring a patient who is currently walking the path of glioblastoma. He is currently a 3-year survivor. He will be running in the Pittsburgh Marathon in May, and I will be sharing a bit more about his story in April. But until then, we are working hard and diligently to get all of our stories put together. We have a jam-packed season with some months actually hosting 2 episodes and not just 1. We will have some great video episodes with some very special guests along the way. And you'll be able to find those episodes on our YouTube channel at the Game on Glio podcast. So please like us on YouTube and subscribe because you'll be seeing some of those special features on that channel. And until we start Season 2, I would love for you guys all to continue following us. Engage with us on Instagram and on Facebook at Game on Glio. Share your stories, leave us comments, let us know how this has helped you. We love talking to all of you, and I try so hard to answer all of your emails, your DMs. I try to get back to as many of you as I possibly can. I'm an advocate for you, even as I continue my own healing journey. So thank you to all of you for listening to the Game on Glio podcast. This was an amazing last episode of Season 1. Again, Season 2 kicks off at the end of May of 2022, so in just a couple of months. And along the way, we'll be sharing stories and tidbits and more information on both our Instagram page at Game on Glio Podcast and on our Facebook page at Game on Glio. Enjoy your spring, and I will see you guys for Season 2 of the Game on Glio podcast.